Male infertility. Introduction. The testis has two functional compartments: the seminiferous tubules containing germ cell population and Sertoli cells, the interstitial compartment containing Leydig cells. The hypothalamus secretes GnRH, stimulating the pituitary gland to secrete FSH and LH. FSH stimulates Sertoli cells to produce androgen-binding protein and inhibin, ABP. LH stimulates Leydig cells to produce testosterone. ABP carries testosterone to the seminiferous tubules to stimulate spermatogenesis, which proceeds as follows: spermatogonia, 46 chromosomes, divide by mitosis, giving rise to primary spermatocytes, 46 chromosomes, which undergo meiosis to be transformed into secondary spermatocytes, 23 chromosomes, and then to spermatids, 23 chromosomes. Spermatids are round cells that undergo a process called spermiogenesis, which is a metamorphosis to give rise to the spermatozoon, which have the characteristic shape, head, midpiece, and tail. From the lumen of the seminiferous tubule, sperms pass to the retitestis, then along the vasa efferentia to the epididymis. The epididymis is a single, highly convoluted tubule, about 5 to 6 meters long. Sperm transport into the epididymis take 2 to 3 weeks, a period essential for sperm maturation. At ejaculation, spermatozoa stored at the tail of the epididymis are expelled by the peristaltic waves along the vas deferens to posterior urethra. Seminal plasma volume is mainly formed by seminal vesicles, 60%, and prostate, 30%. The spermatozoa and the epididymal plasma form the remaining 10%. Definition of infertility. Infertility is defined as childless marriage after at least 1 year of regular unprotected sexual relation or intercourse. Infertility in males can either be primary or secondary. Primary if the man has never been able to induce conception to his wife. Secondary if infertile man has previously been able to impregnate his wife. Etiology: pre-testicular causes, testicular causes, post-testicular causes. Pre-testicular causes: hormonal or systemic disorders. Hormonal: hypothalamus, pituitary, thyroid, suprarenal. Systemic disorders: hepatic renal malignancies. Testicular causes: congenital traumatic inflammatory neoplastic vascular, congenital Klinefelter syndrome, Sertoli cell-only syndrome, cryptorchidism. Traumatic: excess heat exposure, irradiation, gonadotoxins. Inflammatory: mumps, orchitis. Neoplastic testicular tumors. Vascular causes: varicocele and testicular torsion. Post-testicular causes: mechanical infertility, obstructive infertility, and immunological infertility. Then we have male accessory sex gland infections. Another classification is to divide the causes of male infertility under 3 main headings: functional, obstructive, and mechanical. Functional infertility. This includes causes of defective sperm production and function, congenital traumatic inflammatory endocrine drugs and chemicals, immunological, and varicocele. Congenital Klinefelter syndrome, Sertoli cell-only syndrome, undescended tests, traumatic torsion tests, inflammatory mumps, orchitis, prostatovesiculitis, endocrinal, pituitary disorder, hypogonadotropic hypogonadism and hyperprolactinemia, thyroid disorder, myxedema, adrenal disorder, adrenogenital syndrome, drugs and chemicals, antimitotic and cytotoxic drugs, hormones, estrogen, anti-androgens, and testosterone, irradiation, gamma rays, X-ray, large dose ultrasound, excess heat exposure, occupational and pathological, immunological, anti-sperm antibodies, and varicocele. Varicocele is a dilatation, elongation, and tortuosity of veins draining testis, especially pampiniform plexus of veins. Types: primary and secondary. Secondary varicocele is due to increased venous pressure secondary to abdominal tumor, hypernephroma. Primary varicocele, affecting about 20% of the male population, caused by congenital weakness of the smooth muscles in the wall of veins and incompetence of their valves. Symptoms: asymptomatic, usually. Infertility: testicular pain mostly related to sex congestion. Relation to fertility: not all varicocele patients are infertile. Varicocele can affect semen picture and lead to infertility by disturbance of testicular thermoregulation with increased intratesticular temperature, reflux of renal and suprarenal metabolites such as catecholamines into the testes through incompetent valves between the left internal spermatic and renal veins, hypoxia of testicular tissue, epididymal dysfunction. Examination. Varicocele can be bilateral, but it usually occurs more on left side due to left testis is more dependent. Left testicular veins open into left renal vein perpendicularly, while the right ones open into the inferior vena cava obliquely. Compression of the left renal vein between left renal artery and superior mesenteric artery. Grade 1, 2, 3. Grade 1, palpable thrill with Valsalva's maneuver. Grade 2, palpable dilated veins feel like a bag of worms. Grade 3, veins are dilated to the degree that makes them visible. Investigations. Doppler and duplex ultrasound, scrotal thermography, venography, scrotal scintigraphy. Treatment. Conservative and surgery. Conservative. No treatment is required if the patient is asymptomatic and the varicocele is not affecting semen picture or testicular size. Surgery. Varicocelectomy is indicated if the patient presents with orcalgia or infertility. Surgical ligation of the varicocele is performed by high retroperitoneal, inguinal, or subinguinal approach. Improvement in semen parameters and pregnancy rate occurs within 2 years post-operatively in about 2/3 of the patients. Obstructive infertility. This refers to defective sperm transport due to one of the following causes: congenital, traumatic, congenital, bilateral absent vas difference, ejaculatory duct obstruction, traumatic, vasectomy for male contraception, accidental during hernia operation in childhood, post-inflammatory, post-epididymitis fibrosis. Then we have mechanical infertility. This refers to normal sperm production, function, and support, but the problem is failure of sperm deposition in the posterior vaginal fornix and its transport along the cervical canal. Sexual disorders and anatomical disorders. Sexual disorders: erectile dysfunction, severe premature or retarded ejaculation. Anatomical disorders: perineal hypospadias. Another classification based on clinical approach based on semen: azoospermia, oat, oligoathenoteratoazoospermia, normal semen, and isolated defects. Azoospermia: obstructive and non-obstructive. Oat, oligoathenoteratoazoospermia, milder forms of defective sperm production, partially unilateral obstruction. Common causes: varicocele, genital tract infection. Normal semen, idiopathic infertility. Female factors: isolated defects, low semen volume, necrospermia, immotile sperm, absolute isolated teratoazoospermia, hyperviscosity. Diagnosis of male infertility: history taking, personal history, type of fertility, primary or secondary, consider date of the last childbirth or abortion, duration of infertility, consider previous use of contraceptives and long periods without sexual relationship, occupation, heat, irradiation, chemical exposure, residence, endemic diseases, special habits, smoking, alcoholism, and addiction, sexual history, age of puberty, frequency of sexual intercourse, severe premature ejaculation or erectile dysfunction, previous use of contraceptives or postcoital antiseptics, past history, drugs related to infertility, antiemetics, antimitotics, estrogen, androgen, anti-androgen, colchicine, cimetidine, natrifurantoin, propranolol, operations related to infertility, bladder neck operations, inguinal hernioctomy may lead to injury of the vas, retroperitoneal surgery may lead to an ejaculation, history of disease and conditions related to infertility, bilharzism, epididymoorchitis, tuberculosis, mumps orchitis, undescended tests. Examination: general, local, general, gynecomastia, male secondary sexual characters, hair distribution, voice, muscle development, fat distribution, height, span ratio. Local examination: penis, testis, epididymis, vas deferens, spermatic cord, and PR examination. Penis, urethral orifice, hypospadias or epispadias may cause mechanical infertility. Testis, if palpable or not, its size and consistency. Epididymis, epididymal nodules denote obstruction. Vas deferens, if present or absent, and if it is beaded due to tuberculosis. Spermatic cord for the presence of varicocele. PR examination for prostate size, consistency, and surface regularity, and seminal vesicles. Normally they are not felt. Investigations: semen analysis, biochemical markers, and microscopic examination. Normal semen parameters: physical, microscopic, and biochemical. Physical characters: color grayish-white, volume 2 to 5 milli, pH alkaline, liquefaction type. Normally semen forms a coagulum at ejaculation and liquefies in less than 30 minutes. Microscopic examination: sperm count more than 20 million per milli and less than 250 million per milli. Sperm motility: 50% or more of the spermatozoa show active forward progression after 2 hours of ejaculation. Sperm morphology: abnormal forms is less than 35%. Biochemical markers not routine. Determination of some semen markers may help in some clinical conditions. Fructose estimation: seminal vesicle marker may be requested if bilateral congenital absence of vas difference is suspected. L-carnitine estimation epididymal marker may help differentiate pre from post epididymal obstruction. Abnormalities of semen analysis: abnormal physical parameters, color disorders, volume disorders, non-liquefied or delayed liquefaction. Non-liquefied or delayed liquefaction due to prostatic dysfunction. Volume disorders: aspermia or hypospermia. Aspermia: absence of semen at ejaculation. Hypospermia: low semen volume less than 2 milli. Color disorders: deep yellow or red brown, deep yellow infection and jaundice, red or brown hemospermia. Abnormal microscopic parameters: azoospermia, oligosospermia, polysospermia, athenospermia, teratospermia. Azoospermia: absence of sperms in the semen. Oligosospermia: sperm count less than 20 milli per milli. Polysospermia: more than 250 million per milli, usually associated with poor sperm motility. Athenospermia: sperm motility is less than 50% after 2 hours. Teratospermia: abnormal sperms more than 35%. Advanced semen analysis: CASA, computer-aided semen analysis. Advantages: objective, new parameters, velocity, staining for pus cells, supravital staining for vitality, electron microscopy, sperm function test, HOS, hypoosmotic swelling test, acrosome reaction, zona-free hamster ova penetration assay, chromatin decondensation. Causes of azoospermia: functional and obstructive. Functional: failure of sperm production by testes. Treatment is directed towards the cause, but usually ICSI is required. Obstructive: failure of sperm to transport due to bilateral obstruction of the epididymis, vas deferens, or ejaculatory ducts. Treatment is designed to bypass the obstructive part. Then we have how to differentiate the obstructive from functional azoospermia. The testis size in the functional is small or normal, while an obstructive is normal size. FSH level is elevated in testicular cause and reduced in pretesticular cause. This is in the functional azoospermia, while it is of normal level in obstructive azoospermia. Testis biopsy is abnormal spermatogenic in functional azoospermia with maturation arrest and tubular hyalinization, while it's normal spermatogenesis in obstructive azoospermia. Causes of oligosospermia: idiopathic varicocele, unilateral undescended tests, heat exposure, unilateral obstruction, bilateral partial obstruction, small doses of radiation, and gonadotoxins. Causes of athenospermia is usually associated with oligosospermia when it shares the same causes: isolated immotile cilia syndrome, chronic prostatitis, anti-sperm antibody. Causes of oligosospermia when it's associated with athenospermia: idiopathic varicocele, unilateral undescended test, heat exposure, unilateral obstruction, bilateral partial obstruction, and small doses of radiation and gonadotoxins. Causes of teratospermia: varicocele, gonadotoxin, and idiopathic. Causes of aspermia: absence of seminal fluid at orgasm, retrograde ejaculation. Instead of going out of the urethral orifice, semen passes backwards to the bladder. Secretory aspermia: lack of seminal fluid formation due to hypogonadism or post-inflammatory fibrosis of the prostate. Non-emission and ejaculation: failure of contraction of prostate seminal vesicles and vas and VAS at orgasm may occur due to sympathetic denervation after radical pelvic surgery. Causes of hemospermia, blood and semen, bilharzia, seminal vasculitis, hypertension, blood diseases, coagulation defects, prostatic calculi, and cancer prostate. Hormonal profile, testicular biopsy, open biopsy, needle biopsy, differentiate obstructive from non-obstructive azoospermia, histopathological types, normal, hyalinization, Sertoli only syndrome, spermatogenic arrest, hypospermatogenesis, anti-sperm antibodies, when to test for antibodies, idiopathic infertility, poor postcoital tests, semen, athenospermia, autoagglutinin, and hyperviscosity. Imaging, scrotal ultrasound, transrectal ultrasound, abdominal ultrasound, vasography, and venography. Scrotal ultrasound, scrotal swellings, size, and echogenicity of the testis and hydrocele. Varicocele, subclinical varicocele, confirmatory. Transrectal ultrasound, low semen volume, ejaculatory duct obstruction. Abdominal ultrasound, undescended tests. Treatment of male infertility, prophylaxis, early surgery for undescended testes before the age of 2, early correction of testicular torsion before 4 hours, early management of urogenital infections, avoidance of gonadotoxins, irradiation, and gonadotoxic drugs, cryopreservation of semen before cancer, chemotherapy, and radiotherapy, therapeutic strategies, medical treatment, specific treatment for specific disorders, bromocriptine for hyperprolactinemia, corticosteroids for immune infertility, antibiotics for infection, non-specific treatment for idiopathic causes, androgen therapy, anti-estrogen therapy, human chorionic gonadotropin, and human menopausal gonadotropin. Then we have surgical treatment, varicocele, varicocelectomy, epididymal tail obstruction, epididymovasostomy, basal obstruction, vasovasostomy, undescended testis or orchiopexy, torsion testis, detorsion, and orchiopexy. Assisted reproductive technology, ART, refers to all procedures that help bypass barriers for successful fertilization. It's the last step in management of resistant and unexplained infertile males, but sometimes it can be a first line, especially in azoospermic cases. Artificial insemination, husband, male indications, functional infertility or mechanical infertility or unexplained infertility, steps of artificial insemination, husband, induction and monitoring of ovulation, semen processing, methods of insemination, intracervical, intrauterine, or intravaginal insemination, intracervical for mechanical infertility, and cases with low semen volume, intrauterine insemination, intracervical hostility and immunological infertility, intravaginal insemination in cases of deposition failure, in vitro fertilization and embryo transfer, IVF. Mature oocytes are incubated into culture medium with processed sperms, and after spontaneous fertilization, embryos are transferred into the uterus. This method was mainly performed for cases with tubal obstruction with normal semen or mild semen parameter disorder. Gameto-infrafallopian transfer, GIFT, and zygote intrafallopian transfer, ZIFT, are now considered as obsolete techniques. Gamete micromanipulation. Gamete micromanipulation involves microscopic handling of sperms and ova to facilitate fertilization, with the main advantage of reducing the number of sperms as needed to fertilize oocyte up to single sperm. These techniques are partial zona dissection and drilling, old methods involving interruption of zona pellucida to facilitate sperm entry, subzonal insemination, SUSI, old method entailing placement of few sperms into the pivot line space, intracytoplasmic sperm injection, ICSI. This is the most popular method in ART, so it requires only one viable sperm to inseminate one oocyte. It can be used in the severe semen parameter disorders up to azoospermia, where sperms may be retrieved from the testis or epididymis. Sexually transmitted diseases, STDs, refer to a group of infectious diseases which predominantly spread through sexual contact. Epidemiological aspects of STDs. By epidemiology, study of various factors which affect incidence, prevalence of a disease in the community. Factors affecting prevalence and incidence of STDs include age, sex, marital status, special habits, occupation, socioeconomic standard, medical condition, religious attitude. Religious persons are less prone to develop STDs than others. Medical conditions. Patients with medical conditions require repeated injections and blood transfusion, higher chance to develop blood-borne STDs. Socioeconomic standards. Occupations. STDs are more common among alcoholics and drug addicts. Single people are more vulnerable. Males tend to present to STDs more than females. Age, among sexually active from 15 to 35 years age group. Sex education and cultural level. Lack of knowledge and preventive method leads to their prevalence. Sexual orientation and preferences. Environmental factors. General community factors which favor higher incidence and prevalence of STDs are poverty, development of new communities, modernization, industrialization, illegal prostitution, tourism, lack of legalization against illegitimate sexual practice. Agent factors. The prevalence of STDs in a community is affected by certain factors related to the causative agent, rate of organism multiplication, virulence of the organism, susceptibility to chemotherapeutic agents, antibiotic resistant strains, nutritional requirements of certain bacterial strains. Prevention and control aim to complete elimination or reduce incidence to low endemic levels. Methods: reduce exposure, delay sexual exposure or reduce partners, reduce transmission efficiency, safe sex, reduce duration of infectiousness, early detection and treatment of cases, sex education, contact tracing, classification of STDs according to the causative agent, bacterial and viral, bacterial, syphilis, chancroid, lymphogranuloma venereum, viral, AIDS, herpes progenitalis, condyloma acuminata, protozoal, parasitic, protozoa trichomonas vaginalis, parasitic, genital scabies. According to clinical presentation, ulcer syndrome, syphilis, chancroid, lymphogranuloma venereum, granuloma inguinal, herpes progenitalis, urethral discharge syndrome, gonorrhea, non-gonococcal urethritis, systemically presenting STDs, AIDS, viral hepatitis B and C. Other local presentations: condyloma acuminata, molluscum contagiosum, genital scabies. STDs causing ulcers: syphilis, chancroid, lymphogranuloma venereum, granuloma inguinal, and herpes progenitalis. Syphilis, treponema pallidum. Mode of transmission: sexual contact and asexual contact. Sexual contact: normal heterosexual relationship, chancre develops on the genitalis. In orogenital sex, it develops on lips and oral mucosa. In homosexuals, it develops on the anus or within the anal canal. Asexual contact: chancre may develop on the fingers of the physicians examining the lesions without gloves. Sex education, Then we will go to the breast of a woman, of lactating woman, congenitally syphilitic child, transplacental, from an infected pregnant woman to the fetus. Blood transfusion, contaminated needles and blood transfusion introduces tropina directly to the bloodstream. Clinical presentation in such case will be secondary stage lesions without primary stage, a condition known as syphilis dembele. Classification: acquired syphilis, congenital syphilis. Acquired syphilis: early infectious phase, first 2 years of infection, late non-infectious phase after 2 years of infection. B, early infectious phase, primary, secondary, early latent, while the late non-infectious phase, late latent stage, benign tertiary stage, malignant tertiary stage. Cardiovascular syphilis, neurosyphilis. Congenital syphilis: early infectious phase, first 2 years of life, no primary, and there is secondary or early latent. Latent non-infectious phase from 3rd year of life, late latent, benign tertiary, malignant tertiary. Stigmata: scars and deformities left after early and late lesions persist for life. Acquired syphilis: primary, chancre, genital 95%, extragenital 5%. Start as macule, papule, ulcer, highly infectious, single, plainly surrounded, well-defined, indurated base, dull red floor with grayish scab. Spontaneous healing 3 to 10 weeks. Thin, atrophic scar. Secondary: Appears after a few weeks, skin rash, mucus patches, condyloma lata, generalized lymphadenopathy, constitutional symptoms, other hepatitis, periostitis, meningitis. Latent stage, serologically positive, clinically free. Period from the end of the secondary stage to the second year from the appearance of the primary stage. Patients clinically free but serologically positive. In this stage, clinical and serological relapses may occur, despite absence of clinical signs, but it's infective, mainly by blood. Early latent infective, late latent non-infective. Benign tertiary, gamma, skin, mucous membrane, bones, viscera, testis, liver, stomach. Diagnosis of syphilis, dark ground microscopy and serological tests. They become positive only late in primary stage. 50% are positive during the Schenker stage. 100% are positive in the secondary stage. Serological tests are two types: non-specific and specific. Non-specific VDRL and RPR, while specific TEFA, FITA, TPI. Then we have a comparison between non-specific and specific. The non-specific are used as screening tests. The patient's serum is tested against cardiolipin antigen, give false positive results in collagen diseases, leprosy, drug addicts, and pregnancy, while specific tests are used as confirmatory tests if patient has positive non-specific test. Patient serums tested against treponemal antigens. They give positive results only in treponemal diseases. Treatment: one of the following drugs can be used: procaine penicillin, bendazine penicillin, other antibiotics, and treatment of congenital syphilis. Procaine penicillin for 10 days in early acquired syphilis, for 20 days in late, 60,000 international units per day intramuscular. Bendazine penicillin for primary stage, single injection, secondary 2 injections separated by 1 week, tertiary 3 injections separated by 1 week, 2.4 million units. Other antibiotics: if the patient is allergic to penicillin, we may give erythromycin or tetracycline. Erythromycin 500 mg per 6 hours for 15 days in early cases and for 30 days in late cases. Tetracycline can be used in the same dose schedule, never in pregnant syphilitic women. Then treatment of congenital syphilis: procaine penicillin in a total dose of 50,000 international units per kilogram divided on 10 daily injections. Chancroid. Cause of organism is Haemophilus ducreyi. Clinical presentation, incubation period 2 to 5 days. Genital ulcer, multiple small shallow painful ulcers which bleed easily on touch. Regional lymph nodes, inguinal nodes, are usually unilateral affected. Become acutely inflamed, swollen, tender. Later methods appear abscess-like and break down, forming a sinus, oozing pus, inflammatory. Diagnosis: gram stained smear, gram-negative bacilli, and culture. Treatment: oxytetracycline, doxycycline, minocycline, macrolides, erythromycin, Rolide, Visromax. Oxytetracycline 500 mg per 6 hours for 21 days, doxycycline 100 mg per 12 hours for 21 days, minocycline 100 mg per 12 hours for 21 days, macrolides, erythromycin 500 mg per 6 hours for 21 days, Rolide 300 mg per 12 hours for 21 days. Then we're gonna discuss lymphogranulonum venereum by Chlamydia trachomatis L123. Incubation period 7 to 15 days. Genital ulcer: initial papular vesicle breaks down to an ulcer, which is usually transient, disappearing in few days. Regional lymph nodes: chlamydia spreads along lymph vessels to inguinal, leading to inguinal lymphadenopathy. Bilateral: enlarged lymph nodes get matted, forming sausage-shaped swelling below and above inguinal ligament, leaving characteristic sign of a groove in between. When the nodes break down, they open by multiple sinuses, discharging semicaseous material. Urethral discharge. Systemic symptoms: fahem, arthralgia, erythema nodosum, and sometimes meningism. Diagnosis: obligatory intracellular organism. Chlamydia is diagnosed by James stain, swab examination, tissue culture, direct immunofluorescence, PCR, ELISA, freeze intradermal test. Treatment: erythromycin 500 mg per 6 hours for 21 days, tetracycline 500 mg per 6 hours for 21 days, doxycycline 100 mg per 12 hours for 21 days. Then we have granuloma inguinal. Causative organism is Bacterium granulomatous or Donovanus gram-negative bacilli. Incubation period 2 to 6 weeks. Genital ulcer. Granulomatous lesion develop on the genitals, breaking down into ulcers with velvety appearance and raised everted edge, clinically resembling malignant ulcers. Regional lymph nodes are not affected, but subcutaneous granulomas in the inguinal region may be mistaken for enlarged lymph nodes, pseudobubo. Diagnosis: biopsy reveals characteristic bacilli within histiocytes, Donovan bodies. Treatment: tetracycline 500 mg per 6 hours for 21 days, erythromycin 500 mg per 6 hours for 21 days. Then we have herpes progenitalus, genitalis. Causative organism: herpes simplex type 2, causes more than 90% of cases. Herpes simplex virus type 1 is responsible for less than 10%. Incubation period 2 to 7 days. Regional lymph nodes usually enlarged and tender. Systemic manifestations: the primary attack is associated with constitutional symptoms, but recurrences are not. Genital lesion can occur anywhere on the genital with tendency to be peri-orofacial around the urethral orifice and anal orifice. Burning sensation usually precedes the appearance of grouped vesicles on an erythematous base. These vesicles either rupture, forming superficial erosions, or get secondary infected, leading to pustule formation. Dryness of the contents of the vesicle or pustule leads to formation of crusts. Spontaneous healing take 1 to 2 weeks, but recurrences are common, precipitated by friction, sexual intercourse, or psychic stress. Complications: secondary infection, sacral radiculitis. Herpes in pregnancy may lead to abortion, congenital and neonatal herpes in the fetus. Cancer cervix. Systemic dissemination in immunocompromised patients. Recurrences are the most troublesome complication in sexual life. Diagnosis: tissue culture for virus, PCR DNA probe. Treatment: acyclovir local, cream, and systemic tablets. STDs causing urethral discharge. Pathological and physiological. Physiological: prosman. 1 to 2 drops of mucoid discharge are secreted from Cowper's and Litter gland during sexual excitation to lubricate the urethra and neutralize remnants of acidic urine. Prostaturia in unmarried males and in those without regular sexual outlet. Prostate may be congested and full of secretion. This may be expelled during straining, at the end of micturition, or during defecation. Pathological: gonorrhea, non-gonococcal urethritis. And this concludes our part for today.